Welcome back. And as you heard in our previous interview with our previous guest, it is up to the South African public to be active citizens to actually influence where this country goes and the sort of policies that government formulates. Now, the public has until September the 21st to comment on NHI insurance systems. Two bills at stake here, the Medical Aid Schemes Bill and the National Healthcare Insurance Bill. And I'm currently discussing the matter of NHI with Dr. Pillay, who's the Deputy Director General in the Department of Health responsible for NHI. And of course, with me here in studio is Marius Roodt from the Institute of Race Relations. Now, let me just move on to the question about medical aid schemes and how they are likely to be affected by this. Marius, let's take your take first.
I think a lot of medical aid schemes will probably be affected by this, as NHI is a mandatory system, and to fund it, people will probably have to pay higher taxes. This means people will have less disposable income to likely pay for medical aids, so they'll probably see a decline in membership for quite a few of them. As the bill also stands, medical aids will probably, when NHI is implemented, only be able to cover certain conditions, not all conditions as they do now. So they'll probably also likely see a decline in medical aids.
Well, Dr. Pillay, your take on that, the impact that this will have on medical aid schemes?
Well, if we look at the medical aid scheme sector currently, if you take a household that has a disposable income of around 20,000 Rand per month, they on average, if they took a standard medical scheme cover for their family, would probably spend around 3,800 Rand. That's about 19% of the disposable income of the household would be going towards medical scheme expenditure or healthcare expenditure. By the year 2030, that same household will be spending about a third of their money based on the medical inflation in the medical scheme sector on medical scheme and healthcare expenditure. Under the NHI, that household would be spending far less because their tax contributions in order to fund the NHI will be far lower than what they're currently spending. So households will be far better off under NHI compared to what's currently happening in the medical scheme sector. So yes, households will be contributing through taxation. They'll be contributing far less than what they're contributing currently to their medical schemes. And if they wish to contribute to medical schemes, they would only be buying services that the NHI will not be covering. So households, whether they have a medical scheme cover currently or not, will be far better off under NHI than what they are currently.
So, Marius, you also say that a staggering 85%, according to you, of public clinics and hospitals currently do not comply with basic norms and standards. Do you not believe that perhaps the implementation of a scheme like NHI could bring relief to those who actually have to use these facilities?
It's hard to see how that would happen. We don't think it's necessarily a question of resources in the healthcare sector. As we said before, we think it's more likely linked to mismanagement, corruption, and no real consequences for it when there are mistakes made in the public healthcare system. So we don't know if NHI will necessarily lead to this being improved. So as I've said before, one of the solutions we think is to expand the number of people that can access private healthcare through a number of interventions that we think can be made.
And if I could bring that to you as well, Dr. Pillay, with regard to how NHI funding could possibly fix what is wrong in the public sector right now, how is it likely to do that?
The NHI introduces a system of a purchaser-provider split, which means that the public health system will operate on the same basis like what the current private health system operates, which means the National Health Insurance Fund will be purchasing services from public facilities and private facilities. Where a public facility is not delivering the quality of services and the quantity and efficiency that's required, then clearly that public health facility will have to be brought up to speed, because clearly it would not be able to continue to operate in the NHI like it is currently operating now, because clearly the fund will not be transferring funds to it if it is not operating at that optimum level. So in terms of quality, in terms of financing, and in terms of outcomes. So clearly under the NHI, there will be huge differences in the way the public sector is currently operating. I also want to come back to the point Mr. Roodt made about health professionals emigrating. I've been meeting with a number of the health professional groups over the past few months, and none of them have indicated that they're going to be immigrating. But even if somebody was suggesting that they're going to immigrate, my question is always where you're going to immigrate to. If you go to the UK, Canada, Australia, New Zealand, which are the usual places health professionals from South Africa immigrate to, all of them have a national health insurance system. All of them regulate the prices at which health professionals are paid at, and all of them have a single central fund. So where is it that you want to go to that you're going to have a different system? I don't understand.
Well, I wish we had more time to continue this discussion, but unfortunately we don't. Marius Roodt from the Institute for Race Relations and Dr. Pillay, Deputy Director General in the Department of Health, who is responsible for NHI. Thanks to both of you for your contributions this morning. And I hope it actually goes some way to getting the broader public to understand exactly what the issues at play are with regard to NHI, and hopefully we'll have more discussions in this regard. But remember the date, September the 21st, that's my birthday. That's until when you have to make those submissions with regard to those two bills. Let's take a break.